And now we will be hearing from Dr. Ashley Fansher from the University of North Dakota.
Hi, everyone. First, I'm a social scientist, so it has been an eye-opening day so far. I'm trying really hard to learn new things. So my training is in criminal justice and specifically violence against women. And so today I'll be talking about the health effects of victimization in North Dakota. So research shows that interpersonal victimization, and when I'm talking about that, I'm specifically talking about sexual assault, either from any relationship or intimate partner violence. This term's often used interchangeably with domestic violence. I don't use that term because in the statutes, like criminal statutes, domestic violence is any violence that occurs in the home. So this can be between family members, roommates, etc. So intimate partner violence is specifically violence that's occurring between former or current partners. So that is why I use intimate partner violence. Um, and that is going to include, we often think of it only as physical assault, right? Bruises, things like that. But it also is going to include sexual assault and coercion, as in threatening somebody, putting extreme pressure on them. And this, I mean, until 1993, at the federal level, marriage was a defense against rape if it was your wife. So this is something that we keep talking about, but also it's going to include any sort of psychological violence as well. So belittling things, belittling threats, things of that nature. There is a lot of research linking physical assault with mental health. And that shows that individuals who experience physical, intimate partner violence have worse mental health outcomes. What is missing from this, and why I wanted to look at this more, is the effects of sexual assault from any partner or from any relationship, friends, acquaintances, etc., not just intimate partners, and also the effect of these things on physical health outcomes. Because as we've all experienced in this room, probably extreme stress, right? That can take a physical toll on your body as well. And so looking at how those things connect. It's estimated that IPV among rural victims is not only more frequent, it is also more severe in nature, meaning that these individuals are experiencing it at much higher rates. However, the issue with a lot of this research and why I wanted to explore this more is vast majority of this research and almost all of it that's United States based is in Appalachia. There's really nothing in North Dakota. There's been one study that's done, but it was on oil boom towns, which is a very specific targeted location. Any estimates that we have on these crimes in North Dakota is from the FBI, which is the main crime. Anytime you see crime stats on the news, that's going to be the FBI. A downside with that is that it only is going to catch victimization that has been reported to police. Okay, so anytime you see that, know that it's only information coming from that's been reported, and that sexual assault and intimate partner violence are the least reported crimes. Right? It's estimated it's gone up, but about 5-10 years ago, it's estimated that only about 8 to 10 of sexual assaults are reported to police. So those numbers, huge underestimate. And violence that occurs at the hand of a stranger is more likely to be reported. And because these crimes are more likely to be committed by an intimate partner, even more of an underestimate. So aren't all rural locales the same? No. That's why we're doing this. So I've got two different maps here. One is showing the population density in Appalachia versus North Dakota. And also just a quick comparison of these two regions. So generally when Appalachia is considered much larger population, obviously North Dakota, much lower population. If you're in the dating pool here, it's rough, right? So North Dakota, significantly more white, younger, more likely to have a college degree, more likely to, or making significantly more money on average, lower unemployment rate, and our population is increasing. So it appears that North Dakotans are in a better place financially than Appalachia. And also, but the big difference, right, is that we are more spread out in terms of our regions. So for this study, we were trying to, it was me, trying to look at the effects of victimization among North Dakotan women. So self-identified female patients of Sanford Health. So Sanford was our main partner, age 18 above. We did focus on adults because there is a big distinction in the literature among causes and consequences of child victimization. So we did want to separate that out. Individuals were recruited through Sanford MyChart. They received an email saying if they met these only two qualifications, that we were doing a research study and it's okay to contact them. They were incentivized by a raffle for a $100 Amazon or Visa gift card, depending on their preference. And we gave out 200 of those. So my thought was that we could give everybody $20, or we could say you could win one of 200 $100 gift cards, and that would incentivize me. $100 is going to incentivize me. So the request was sent to 33,000 people. About 10% of those actually saw it. We got a general positive response. 1,300 actually began the survey. We had 1,100 that completed at least 75% of it. And we did have some individuals from Minnesota, from other areas as their primary residents. So we did want to focus exclusively on North Dakota residents. Since we've done this data, we have about 200 more people that we're going to add in for future analysis. Oh, victimization variables. So the first one, we've got the revised conflict scale. This is a very long list of behaviors. All of these components are 6 to 15 questions. So I've provided some examples here. The options are if they've ever experienced it, and then how many times they've experienced it. So for revised conflict tactics scale, that is specifically for an intimate partner. So that is where our IPV is coming from. We've got psych aggression, physical assault, sexual coercion, and then injury. And then for sexual assault from any relationship, sexual contact, these kind of increase with severity, sexual conduct, coercion, attempted rape, or rape. The sexual experiences survey is how this has traditionally been measured. It's a list of behavior items that ask if an individual has experienced these things. We have found as victimologists that asking somebody, have you been raped? You're not going to get as many yeses, because that's a really tough thing for people to admit, especially if they were passed out, especially if they'd been drinking, especially if it was a partner. And so if you ask, has anyone overwhelmed you with continual arguments to have sex? It's a lot easier for somebody to say yes to that than to recognize and acknowledge that they have been a victim of rape. Looking at all these different things. In terms of our health variables, physical health variables, these are, I think all of these are coming from NIH's set of different questionnaires. These all range from 3 to 4 questions. I wanted to keep it as short as possible, but also ask everything possible. So I use the short forms of most of these. Physical function, pain intensity, pain interference, fatigue. The National Health Survey is actually 25 different diagnoses that somebody could have, and it is, have you been diagnosed or had, and there's 25 different yes or no's. So we combined all that into how many diagnoses somebody's had. Global mental health, anxiety, depression, sleep disturbance. Those are our mental health factors. And then healthcare utilization, we're going to look at this as well, trying to see if there's difference in healthcare utilization by rural and non-rural individuals and by victims and non-victims. There are 2 ways that rurality was looked at. One way is on the poster of my graduate student, so you can go see his way of measuring it. His way actually picks up a lot more people. But because so much of North Dakota is rural, I wanted to look at it from a different way, from a different version as well, and that is to look at remote and frontier level status based on the US Census Bureau. So there are 4 levels of remote, and it's how far an individual is from an urban area of this level. This is what's pictured here in blue is level 4. So these are all the areas where an individual is, if they live there, they're over an hour from a remote location of 5,000 people, which to me says decreased services, right? That was the point of looking at that. And also not just decreased services, but also increased what's known as acquaintance density, where you know everybody in town. And so if you've experienced something, experienced a victimization of it, you're less likely to go talk to people and tell them about it because you probably know everybody you're going to report to. And they probably know your significant other or whoever engaged in that behavior. So I'm going to present to you 10 exciting numbers-filled tables. Get ready. So full sample, we know that North Dakota is very white. We just have to open our eyeballs. We're very white. The only differences between the full sample, remote is going to be if they're any of those levels. Very remote is those level 4 people. Right, so we had 80 very remote, 191 living in remote areas. Our other classification, which you can see on Jashan's poster, is about 400 rural. So we've really looked at this in 3 different ways. Remote individuals are significantly more likely to be married, significantly more likely to have kids. So I asked individual income and household income because income is often a barrier to staying with an abusive partner. So I'm looking at, do these women would they have the financial means to leave a situation? And so we see no differences. Half the population makes between $25,000 and $75,000 a year. This is where it gets very sad. So 60% of our sample of North Dakota women has experienced sexual victimization. 60%. 54% sexual conduct, 30%, a third of them have experienced completed rape in our state. Most research of sexual victimization is of college women because most researchers are college professors who have access to college women for surveys. So there aren't a ton of studies of a population, especially this population. If you look at their age, our range was 18 to 89. And our average age was 54. So again, 30% experience completed rape. 70% have experienced intimate partner violence of some sort. It's mainly going to be physical aggression. 25% have experienced sexual assault, sexual coercion from an intimate partner. 16% have been physically injured from an intimate partner assault. These numbers are very high. Interestingly, again, as I mentioned at the beginning, the research mainly in Appalachia, also some in Australia, says that intimate partner violence is higher among rural populations. That actually is not the case in North Dakota. There's no difference for sexual victimization. There's no difference for psychological aggression or sexual coercion. And individuals in remote areas are actually significantly less likely to experience physical assault or injury. So already showing that North Dakota does not fit into the prior research on this. Looking at mental and physical health, comparing remote and non-remote, there are no differences in mental health, which I find super interesting. Individuals living in the most remote places in North Dakota don't have different mental health outcomes compared to individuals not living in a remote area at all. The only differences here are for pain intensity and pain interference, with remote individuals experiencing more pain interference and more pain intensity. We have to this is a wild speculation, but these individuals are probably more likely to engage in hard labor, right? We have a big farming community, so that would make sense. Okay, so comparisons for sexual victimization. It's all significant, all of it. I didn't want to overwhelm you with asterisks. For every type of sexual victimization, we see negative impacts on mental health. So I've got it broken down to the 4 types, but overall, experiencing any sexual victimization, doubling anxiety, double depression scores, higher sleep disturbance scores. And we see that this is highest for individuals who've experienced attempted rape or completed rape. Significantly worse mental health outcomes in terms of having trouble sleeping, depression, anxiety, lower mental health scores. What about intimate partner victimization? Again, it's all significant. lower. And so for all of these psychological, physical, sexual, experiencing injury, worse mental health scores. Almost double the anxiety, double the depression, much more difficulty sleeping, significantly lower mental health scores. Physical health, it's all significant. Again, so this is what has not really, some of this has been looked at, but with sexual victimization and physical health, it's mainly only looked at STDs and STIs. None is looked at, really no research, or at least not really that I could find, looks at these different physical outcomes, physical function, pain intensity, pain interference, related to significantly more health issues, even for sexual contact. Sorry. Oh gosh, my hair. There we go. Okay. Most of it is significant. Actually, the only thing that's not significant is these two squares. So this is fascinating because psychological assault, psychological violence, which is, we think of it as not fully psychological, is still affecting physical outcomes. It's causing more fatigue. It's causing a decrease or an increase in pain intensity. It's causing an increase in pain interference. And it's, I'm saying causes, related to significantly more health issues. Okay, so we've got that. There's not really a difference in rurality and victimization. There is a significant difference in health outcomes and victimization. Is there a significant difference in medical service use? Again, not really, which is fascinating to me. Between remote and non-remote individuals, the only difference in yes or no to any of these questions is if these individuals had gone to an urgent care, and remote individuals were less likely to do that. But we're seeing, I think, just the increased ability to go to virtual appointments, to use the internet, to check in on medical tests, go to your doctor. And there's no difference in remote versus non-remote in they didn't get care when they should. All of our differences come with victimization. Sexual assault victims, significantly more likely to go to urgent care, to go to the ER, significantly less likely to go to an in-person appointment, more likely to do a virtual appointment. But what I think is most important about this is double the amount of individuals who've reported sexual assault did not go to the doctor or get care when they thought that they should. So we see that they're still engaging in these things and still using services, but they're significantly less likely to get help when they should. For intimate partner violence, we see a lot of the same things. Individuals who've experienced intimate partner violence, more likely to go to urgent care, more likely to have a virtual appointment. Again, significantly less likely to get help when they need it. So is North Dakota different? I've kind of already alluded to this. A lot of the reason that, a lot of the motivation to stay with an abusive partner is because of a financial inability to leave that partner. So North Dakota may be different there since our citizens make more money and have higher education levels. Again, there were minimal differences in physical health by rurality, no differences in mental health. So really the thing that mattered here was victimization. All types of victimization led to worse all types of health outcomes. And then differences in medical service use. Victimization matters. These individuals are significantly less likely to get help when they need it. So things to consider. We see that victims need both mental and physical health services, and they're more likely to avoid care when they need it. But also, based on the frequency of these individuals interacting with the medical system, it's happening, right? So victims are coming into contact with medical professionals regularly, and there's some sort of disconnect happening in terms of them, I think, in terms of them following up with those medical professionals when they need help and when they've experienced victimization. So my suggestion so far would be targeted advertisements, talking about confidential reporting, confidential resources, especially in these more rural areas, trauma-informed training, which is actually, I suggest this, I work with police departments as well. This is like a 4-hour training that you can do, right? It starts small and is worth the money, right? Because if you are engaging with if you have someone engaging with a victim who doesn't know how to talk to a victim, it doesn't seem like a safe place. Not only is that person going to not talk to them, they're not going to come back next time either and say anything. Right, and then review of screening procedures to see how we can pick up on more victimization in that process. So takeaway from this is there's a lot. We don't want to think of it in North Dakota because we're such a nice place with so much ranch and so many fried pickles. But it's happening here, and what can we do about it, right? We have to acknowledge it and then figure out where to go moving forward. Thank you very much. Yeah.
So did I see correctly that they had more than 80% graduates from college?
Yeah, probably.
That doesn't represent the state of North Dakota. So that suggests an overall bias in
85% report a college degree.
You think that bias affected your outcomes? And did you see differences in psychological victimization versus physical victimization? Because you might imagine that at least severity of the outcome would be different. And there's women don't have a lock on victimization.
Yeah, absolutely.
Men could certainly be victimized
Yes.
in a relationship, perhaps not as commonly physically.
Yes.
And so would you expect the results to be the same for men as for women, or would it be something different?
So the reason that I focused exclusively on women in this study is because it was a pilot study, and the number of males I would need to do statistical analysis, I question if I could get them in the amount of time, to be really frank about it. In terms of the bias of the college degree, it's probably we're honestly probably missing out on reporting. We probably got underreporting. So the numbers, if I got more individuals without a college degree, the numbers would probably be lower. Or, I'm sorry, the numbers would be higher because of reporting differences.
Maybe. You don't know that. I mean, that's.
Yeah, I'm just going on like, yeah, but I'm just going on what the past research says about it. They do. Yeah, so research says if you have a degree, you're more likely, if you're more educated, you're more likely to seek help. And so therefore, if we get more people without a degree, I would assume that we would have less people seeking help and we'd pick up even more victimization.
It could just be more sensitive.
Yeah, maybe. Yeah. No, I did not. Yes, absolutely. I was trying to put so much into such a short. Yeah, absolutely. Yeah, but I definitely agree that is an outcome. I hope that we pick that up under the global mental health questions, under sleep disturbance, and some of these other things. Did you have a question?
Yeah. First of all, this is fantastic because nobody's ever done this in before. Really, the only good violence data. It's not even good data. The data we have on violence is from frames, and it's 2% maybe that gets reported.
Yep.
So my work is in perinatal health, and so just wondering, do you have pregnancy status data or recent pregnancy status?
Yes. It's just not in there right now. I have number of pregnancies and the outcome of those pregnancies. So whether
recent, like,
yes, I think I have ever and in the last 12 months. Yep. There's a lot. I try to put as much in there as I could to consider all of these different things and the pregnancy, because the pregnancy options would be live birth, termination, or a miscarriage. I think there's like 2 more options, so I can see how those pregnancies how they've ended up as well. There's one back here. Correct. So the early, again, since these are just preliminary, it's mainly bivariate. What Jashawn looks at is barriers to treatment seeking. So we're going to also do one of our first papers is going to be barriers as the outcome and looking at how all these different things and victimization and reality status and everything works together. Mhm. Yep. Mhm. Yeah. Mhm. In the recruitment, it said relationship and health experiences. And then I'm very happy. I've done a few victimization sites. Very happy to talk to you about it afterwards. Another big part of it is making sure that an individual can stop whenever they want. That's why we have that 75% completion. And they can skip if they're uncomfortable with that. And then also providing the end of the survey provided both free and Stanford-based mental health, because this can be very triggering as well. Yes. Oh, sorry. More later.